Welcome to our program today, Thriving with Parkinson's Disease. This is a foundational program in partnership with our friends with Amneal, and we're going to be covering what to expect, how to advocate for treatment, and lifestyle choices that will improve your quality of life. And PMD Alliance feels very strongly about you being knowledgeable and be able to be self-advocates. So whether you are newly diagnosed and just starting on your journey with Parkinson's, or you've been diagnosed a while, but now you're wanting to get more active or take a more active role in understanding your disease and managing it, this program is for you. So we hope that you will gain some insights and tips to help you understand your symptoms, manage them, and communicate effectively with your doctor. We are recording today's program. We do want you to open up your chat box. That's where you're going to ask your questions. So we'll have opportunity through the program today to ask some of those questions. And I'm excited to introduce our speaker with us today. This is Dr. Ramon Gil. Some of you may have met him before in our programs. He is a movement disorder neurologist. He's president and principal investigator of the Parkinson's Disease Treatment Center of Southwest Florida in Port Charlotte, Florida. He's been an investigator of over 100 clinical trials, primarily focusing on Parkinson's disease. I know Dr. Gil well. What he's going to be talking about is exactly the way he treats his patients. And so I think that you will get a lot of great anecdotal stories probably and comments as he goes through this presentation today. So I'm going to turn it over to you, Dr. Gil. Thanks for joining us.
Thank you. Thank you very much, Anissa. Thank you, everybody, for allowing me and the group from PMD Alliance to enter in your homes, as obviously you are in remote or in this famous Zoom meeting style. And I need to share my screen, so I'm going to go here and there. And now we go here. Let me see. Are we all set there? Can everybody see me? Perfect. Okay. Well, as I was saying, thank you so much for allowing us to enter your homes today. I've been doing this for so many years that when I started, I had a lot of hair and I had a big mustache and the same accent, probably worse than right now, but I've been practicing. So hopefully you'll be able to understand me well. Because what I want you to do, among other things, is not just to learn from this presentation, but I want you to become more empowered and more confident of your knowledge about this disease and the treatment, so you could proactively utilize this knowledge to improve your treatment. There is nothing that disappoints me more to see all of you attending all these big meetings live and all these great companies sponsoring these events and all these doctors teaching you guys, and then you all leave home with all these goodie bags and all this promotional material. And then at the end of the week, you are being treated with the same old medications from the 1970s and the 1980s and early 90s. It's like you go to these meetings to learn that there is a better treatment, but for somebody else, not for you. So I want you to make sure that you ask the next time when you are with your doctors, doctor, is this as good as it gets? Just as like Jack Nicholson in that movie, okay? Is this as good as it gets? Is there anything better for me and my Parkinson's? Because there are realities today that are hard to believe. Like, for example, we have reformulation of all drugs that are very effective for Parkinson's. Actually, they are amazingly effective, and the minority of you are using it. So please join me to learn about Parkinson's today. But when you are joining your doctors, or whoever else takes care of you these days, because now you also have nurse practitioners and other, they call them extenders. Ask them for, why not newer drugs? Why not drugs that are probably more effective than what I am taking? All right, so here we go. By the way, this is a promotional. It's not a promotional, and it's a promotional. I don't even know how you call this these days, but this is sponsored by Amneal in combination with PMD Alliance. And guess what? I'm being paid for doing this, but I won't tell the IRS. I pay enough taxes. All right. So the idea here is to learn about Parkinson's disease and to, as I said before, to use this for your treatment to improve and for your quality of life to be better, and also for your care partners to have a better time accompanying you in this journey. So how common is Parkinson's disease? Well, depends if you ask that to an attorney from one of these firms that are linking Campbell-June and Paraquat and whatever other chemical compound these days, all the spray that they have for the weed killer. There was another product that was recently associated with Parkinson's. And the reality is that Parkinson's is growing in terms of the incidence, not just in this country, but around the world. And most people with Parkinson's have not been in Campbell-June. But there are realities that you need to understand. For example, diabetes has been found to be a high risk factor for Parkinson's. And that's something that you need to keep in mind, because there are plenty of people with diabetes in this country. And guess what? It is known now that patients with Parkinson's and diabetes have much worse disease than non-diabetics with Parkinson's. So you need to keep in mind that if you have both PD and diabetes, you may be able to cure your diabetes. Okay? Something called exercise helps. So, yes, by the year 2037, this amount, 1.64 million, I read earlier this week that it's going to be even higher, because for reasons that we don't know, the incidence is increasing. And perhaps diabetes is one of those factors, but that doesn't make that much money for attorneys, so you won't hear that in the TV. Now, why does Parkinson's patients develop these symptoms that we all recognize? Well, it is because in this condition, the cells in the brain, the neurons that produce dopamine, are dying prematurely. And as the amount of dopamine produced by the brain goes down, then the primary symptoms appear, motor symptoms. But even before the motor, you have non-motor symptoms that we all recognize, and we'll talk about that in a moment. Okay? Now, men get more Parkinson's than women. Now, that is still the case in the new statistics. The ratio seems 3 to 2. Sometimes they talk about 4 to 2, etc. But it is a little higher in males than in females. The onset is around the age 60. We all know that there are a bunch of patients with what we call young Parkinson's, are those that develop the motor symptoms before the age 50, but most are around 60 or beyond. And there are those that we consider older onset of Parkinson's that develop the motor symptoms after the age 70. And there are distinctions for that, and you have to keep that in mind. For example, the younger you are when you develop the motor symptoms of Parkinson's, more tremor you're going to have. And then in the older population, they have very little tremor or no tremor, but they are slower than the younger Parkinson's patients. That is the reason why so often we see patients here that they come at the age 78 or even 80, and they come because somebody suspected Parkinson's disease. And when you go through the history, they have had Parkinson's motor evolving for 5, 6, 8, sometimes even 10 years. Why? Because especially up north, they think that people that are slowing down is just because they are older. Well, in Florida, we don't have that idea. And we want to believe that everybody in Charlotte County is just experienced, and we don't take for granted that if you shuffle, it's because of your back. Or if you are stoop, it's because of arthritis. And if you are slowing down, it's because you are 75. We want to see you at the age 75 playing golf, dancing, having fun, okay? So move down to Florida, and you have more fun those winters that are so cold up north. All right, so 1% of the population over the age 60, we believe, has Parkinson's disease. That has also increased in the recent statistics. Um, in terms of what is the cause of Parkinson's, we have different factors, a genetic component, but you have to keep in mind that when we say a genetic component, doesn't mean that your children will necessarily have Parkinson's. Uh, all we can tell you is the minority of the patients with Parkinson's disease have what we call pure genetic Parkinson's. And those are patients that are young PD. And the risk of passing the disease to your children is higher in those. The younger they get the Parkinson, the higher the incidence of genetic Parkinson's is. As a matter of fact, if a person develops the motor symptoms of Parkinson's disease after the age 50, the children have the same chances of developing Parkinson's than anybody else in the community. Actually, if both parents have Parkinson's after the age 50 in terms of onset, the children have the same risk than others. Okay, so you have to keep that in mind. When we talk about genetics always involving Parkinson's, the way I like to explain that to you is that when we are all born, we have a genetic mosaic. And in the genetic mosaic, we have the colors of our eyes. We bring the how tall are we going to be. We are our personality traits, and even to some extent the diseases that we are going to be prompt to have. Uh, and patients with Parkinson's disease in that mosaic, they are with tendency to be of higher education than non-Parkinson's. And when you choose your professions or occupations, in general, you look for detail oriented occupations, accounting, physicists, teaching, architects, physicians, priests. So there are this type of personality traits and tendencies that is part of the genetic component that comes along with Parkinson's. All right. Also, the environmental factors are a big risk factor for this. That comes really from the days that pesticides were really poorly controlled. They were very toxic. And welders also because of the exposure to manganese. But all those things have been really minimized until now that we hear again all these ads, and everything is because if you pass by Camp Lejeune and you get pregnant and you have depression and you have Parkinson's and you have a car accident, everything is linked to Camp Lejeune, Paraquat, or many of these things that we see in the TV every day. Be careful with how much of that is or is not necessarily the case. Okay, what happens in Parkinson's disease? I mentioned before that the cells producing dopamine are dying. So in the normal brain, in the non-Parkinson's brain, we have dopamine in the presynaptic neurons. The dopamine is released to the postsynaptic neurons, and you have here happy dopamine receptors waiting for the dopamine. And when it clicks, they all work, and there is a signal that provides you with normal movements and many other functions involving coordination, mood, sleep, energy, strength, etc. Now, when you don't have enough dopamine, then the activity is diminished and you don't have a really dopaminergic response. So all these motor symptoms occur. And what are these motor symptoms? You know them all. The tremors, the rigidity, the slowness. And it's not just a slowness, but it's a small movement. Okay, when you are walking, your steps are smaller than otherwise. And then stability, balance, all of those things are typical of Parkinson's, including the speech and swallowing problems. Now, the thing that we learn, believe it or not, eh, relatively recently, I don't know, this seems to me, as I'm growing older, that 20 years is nothing, and then 25 is nothing even. But it's amazing to know that it wasn't until the year 1998 or 2000 that we kind of knew about non-motor symptoms of Parkinson's, and we kind of knew about constipation and bladder issues being part of Parkinson's, but we learned big time in those days in further and more extensive research and analysis of Parkinson's disease that we have a gigantic iceberg, and the tip of the iceberg is just tremor, slowness, rigidity, and balance. And underneath the water, we have a myriad of non-motor symptoms, sleep disturbances, low blood pressure problems, constipation, bladder, anxiety, depression, lack of sense of smell, taste abnormalities. All of those things are part of Parkinson's. And fatigue is one that continues to be a source of frustration and limitation for many of you. And we have been working very hard to develop treatments and improve the quality of life of patients with PD that many times these days is more impaired by the non-motor than the motor symptoms. Why? Because we have developed over the years very effective drugs for the motor part, but not for the non-motor. But we are making progress, okay? We are. Now, you all know this, but it's important to refresh your memory because perhaps some of you may not be aware that the onset of tremor in Parkinson's is always in one side of the body and then goes to the other. And the motor symptoms, the slowness, the rigidity, is always of onset in one side and a few years later goes to the other. Why is that important? Because if a person that is your loved ones or yourself, if you have tremor in both hands from the beginning, it may not be Parkinson's, it may be drug-induced drug-induced tremor, or it could be essential tremor or familial tremor. And also, you need to know that the symptoms of Parkinson's evolve slowly. You don't develop Parkinson's impairing your walking and your mobility. You don't develop that in 3-4 months, but you could develop that when you are being exposed to a medication that causes symptoms of Parkinson's disease. Okay? Now, keep in mind, please, that everybody with Parkinson's has, in a way, a different Parkinson's disease. We always say that there are no two identical patients, and that's very, very true. I am always amazed of how aggressive a patient's Parkinson's could be, in the sense that a person is diagnosed 10 years ago, is well treated, and despite that, in 10 years, maybe quite impaired, and others, go for years and years enjoying a very good quality of life and limited functional impairment. Granted, we, the doctors, are responsible for helping you to receive optimal medical care. Now, you are responsible of following our instructions, and you are responsible for your exercises, your lifestyle, and your compliance. There is nothing more challenging than patients that come here and they expect for me to move to their houses, to give them the medications on time, to get them to the gym, to help them to eat well, and to help them to truly, truly, truly be good patients. And for the most part, guys, when patients do what the doctors say, things work out better. Okay. Now, don't get my advices for investments, or don't get my advices for your kitchen, because those are not areas that I am good. Okay. Now, uh, keep in mind, again, going back to the Parkinson's symptomatology, that it is critical for you not to compare with your neighbor, or not to say, well, my friend Johnny had brain surgery for Parkinson's and he didn't do well, so I don't want surgery for Parkinson's. Be open up, listen to your doctor, uh, understand why you are being advised to have surgery, or why he is on this drug and you are in a different one. Okay. The timing of your medication is very important, and we could go back to that later. Okay. Okay, what is happening here? Okay. Now, the timing of the medication is very important, because we want to keep the light on all the time. It's like Motel 6. We keep the light on for you. Well, that's what we want to do with you guys. We want your dopamine level in your brain to be at a steady level, at a level that is good enough for your symptoms to be minimized. And we don't want, for the most part, for your levels to go down and then up and down and then up. Why? Because the more your levels fluctuate, the more ups and downs you have in the concentration of levodopa in your blood and brain, the more damage the dopamine receptors suffer, and the earlier you're going to develop these dyskinesias. And also, it's like a vicious circle. The more off episodes, or the more fluctuations you have, the worse the off periods get. And you don't like your lights to be off, because when your lights are off, you can't walk, you are anxious, you can't move, you fall. So you want to be on. And on are the good times of the day when your symptoms are minimized. And that your on could be good quality on, or you could have too much light. And when you have too much light being on, that's when you have these kinesias. Because at that point, the concentration of the levodopa in your brain is higher than what you would like, and then the dyskinesias occur. Okay? Now, in this whole conversation of off, on with dyskinesias, etc., there are different terms that you have to learn and become familiarized. We don't have time for that today, but I wrote something called the dimmer switch. And the dimmer switch is better for you to understand because your switches are not like the standard switch on off. Your switch in Parkinson's is really more than like a dimmer switch. You could bring it all the way down and you are off. And the first episode of off in the morning is what we call early morning off. That you don't need necessarily to experience, but most of you do experience a morning off. And that is because your tank is empty and you don't have enough dopamine when you wake up in the morning because you took your last dose of medication the night before. Then you could have a partial on, like you brought your uh, light on in the dimmer switch, but didn't get it really high enough where you want it. So the concentration of levodopa is not high enough to give you the robust benefit that you want. But then you could run out of gas because your medication, guess what? Ah, God, Lord, 3 hours ago I took my medication and my shaking is coming back already. Well, you are wearing off. Or sometimes you could have a stomach problems that we call gastroparesis. You take your medication and the pill stays in the stomach and it doesn't travel to the small intestine where it's going to be absorbed, specifically talking about levodopa, and then you have a dose failure. What does that mean? Dr. Gil, my husband took the medication this morning and nothing happened. That's a dose failure. Or what is called a delay on. And a delay on is very frustrating and very confusing because yesterday I had a patient here uh, that came from another country called Miami. Miami is a different country that we have in Florida. So she came to see us. The family brings her here. And they were afraid that, Dr. Gil, when my mother takes her medication, sometimes she gets worse after the medication. It's like the medication causes the problem. No, the problem is that she takes her medication, she's starting to wear off, and then the medication gets in the stomach and it stays there, and she continues getting worse after the medication. So 1 hour later, this woman is having anxiety, panic attacks, and who they blame? Well, they blame the medication. No, she had a delay on or a dose failure. And then unpredictable off are like when you live in the Dominican Republic and the light goes off from time to time out of the blue sky. Well, that happens in Parkinson's sometimes. And patients take the medication, and without any reason, boom, they go off in the middle of the dose or in the middle of the cycle. All those things happen, and there are different ways for you to address that with your primary care, with your neurologist in terms of how to treat and how to minimize those problems. All right. So your motor symptoms during the off time, you all know, is basically the same thing that we mentioned before. Your tremor, the stiffness, the slowness, the difficulty with your speech, all of them or some of them tend to come back as the medication is wearing off. And then, as I mentioned in the patient from Miami yesterday, that was here yesterday, her wearing off and her off period is characterized not only with a slowness and mobility problem, but she experiencing panic attacks, shortness of breath, hyperventilation, anxiety. She gets stomach pains. She thinks she's going to die. It's very, very impressive to see that, and there are ways to solve that, which she got yesterday here. Okay. So how often do you experience off times? Well, guess what? 90% of you experience at least one of these episodes. And 65% or around 65% of you guys experience at least 2 hours of off time. That's a lot of time to be off. And remember that this is a spread throughout the day, like half an hour here, 1 hour there, half an hour there. And the problem with that is that then you have to almost plan your life around being off. And then you say, well, I don't want to go to the restaurant at this time because I'm going to be running out of gas and so on. Okay. And it happens that more than 20% of the patients with Parkinson's are experiencing more than 4 hours of off time a day. Now, picture this. Most of you are supposed to be awake and active, 16 hours a day. That means that you're in bed sleeping for 8 hours. So out of 16 hours, a quarter of that you are off. So you are giving away a quarter of your life. That's not good. That's not good. That may be good paying taxes, a quarter of your income, but not in your life or in the active life. Okay, actually, 25% is too much taxes, especially for the Washington that we have today. Anyways, now, why do we need to communicate? And I don't know how to put this in a nice, easy context. Make sure, guys, that when you meet with your doctors, that there is open communication. Make sure that you bring written notes and questions. Make sure that you receive enough time to learn what's going on with you and to discuss motor fluctuations on and off, dyskinesias, your treatment with your doctors. Because if you go to see your doctors and in 10 minutes you are in and out and with a refill for medication for 4 months, and that was the extent of the visit, you may need to go to a different restaurant. Okay? All right. Now, how do the medications work? The most effective medication for the symptoms of Parkinson's disease remains levodopa. Hear me. I didn't say the only, I didn't say the best. I said the most effective symptomatic drug for Parkinson's disease remains levodopa. Levodopa works because when you take levodopa, it goes through your stomach and intestine to your bloodstream, goes to the brain, and in the brain is transformed into dopamine, and then you have enough dopamine to stimulate the dopamine receptors and things improve. It's like if you need insulin, you get insulin and the blood sugar goes down. Well, if you need dopamine, here is dopamine in the form of levodopa. Now, there are another group of medications that we call dopamine agonists, and they look like dopamine. So when they make it to the brain, the dopamine receptors look at it, hey, look like dopamine, and they welcome, and it works. However, there are a lot of problems with dopamine agonists in older patients. And remember that most patients with Parkinson's are over the age 60, 65, 70. And the older we are, the more difficult it is to use dopamine agonists. As a matter of fact, they shouldn't be used in patients over the age 70. They are great on young people in the 30s, 40s, 50s, early 60s, and being careful monitoring side effects and selecting the type of patients that you put in these drugs. All right, so levodopa works, let me rephrase. This is a curve or a pharmacokinetic curve of levodopa. Like you take one dose and it goes up and down. Well, this is the shape of the immediate release carbidopa levodopa. This is the form in which Cinemed, or the brand name, the original brand name of levodopa, works. And all the different formulations of levodopa, all the different formulations of levodopa that are based on IR, the pharmacokinetic curve is very similar to this, okay? And the time between this point, 0, and this point narrows over time, as you'll see in a moment. Here you have the area that is considered the window or the therapeutic window. This is the time in which the levodopa levels, the levodopa level goes to this point, and then your symptoms are improved. And then when your levodopa level go above this line, you have these kinesias. Then you improve again, and then you go off. And this is the good on time. This is the therapeutic window. But see, over time, the time that the levodopa lasts in your system narrows down. And then you go up and down, up and down, up and down. And what did I tell you? The more ups and downs you get, the more severe your fluctuations get, the more off time you experience. And then eventually what happens is that because this line goes up over time, you require higher doses of levodopa to get you in this level, and then the peaks will be higher, and you'll experience more dyskinesias. Now, here is an array of options of things that your doctors could do to help you to smooth your response. These are all kind of options that they could choose and work with you. But ain't that easy. For example, the first one, they are telling you, oh, very easy. If your levodopa only works 4 hours, then go ahead and take it 3.5 hours apart. And if you take 4 doses a day and they don't last, then take it 5. And then if 5 doesn't work, take it 6. And they could do that. But the problem is the more ups and downs, the worse you get. You could also add an MAOB inhibitor. These are drugs like rasagiline and safinamide and rasagiline, that are medications that don't do a lot for the symptoms of Parkinson's, but they do prolong a little bit the duration of the levodopa. And they also save your own dopamine in the brain. So I am one of the doctors that find very beneficial to use rasagiline or safinamide early on, or when patients are diagnosed, because we know, based on studies that were conducted in the past, that patients on rasagiline, those patients do better down the road than those that did not use a MAOB inhibition. You could also use what we call a COMT inhibitor, or a COMT inhibitors. These are all these families of Italian guys, entacapone, talcapone, opicapone, and they are all great drugs that prolong the duration of the levodopa, but talcapone is practically no longer used because it hurts the liver. Entacapone works a little bit, but did not resolve the problem of the fluctuations and dyskinesias. And then opicapone, which is the newest one, is very effective, very powerful. You could use it in combination, but your doctor needs to learn how to adjust the dose of levodopa. And for some doctors, that may be a problem. You could also add a dopamine agonist. And by the time you are thinking about adding dopamine agonists because of the motor fluctuations, you probably passed the time of using dopamine agonists. And as a matter of fact, years ago, we participated in a clinical trial to demonstrate the benefit of dopamine agonists doing this. And let me tell you, it's very difficult and most of the time unsuccessful. Uh, you could also add what we call rescue medication. And that's what I did with the lady from Miami yesterday, that she was still wearing off, even though I was using a medication called Rytary, which is extended form of levodopa, or carbidopa levodopa, the real extended release. And I'll tell you later why I say the real one. Now, this patient was running out of gas, even though I was using Rytary 5 hours apart, 4 doses a day, because she has gastroparesis and it's pretty bad. And even though Rytary does better, in my opinion, even in the face of gastroparesis, than the IR, my best resource was to use Imbrija, which is an inhaler form of levodopa. So when she is starting to run out of gas, now the family used Imbrija yesterday in the evening, and they couldn't believe that she did very well. She did not have the wearing off and the panic attacks and so on. And how do I know that that was yesterday? Because she's still here. She's going to be here with us for a whole week, spending in little Port Charlotte. Now, you could also add other drugs like adenosine alpha 2 antagonists, that is istradefylline, that's Nurians, is a new medication that you could take. And this medication reduces the off time some and kind of reduces the severity of the off time, in my opinion. It does give you a better time and it give you a little bit more on time, okay? And then here they are telling you that you could switch to the longer acting carbidopa levodopa. That, in my book, is Rytary, because there is an old generic drug called Cinemet CR or carbidopa levodopa ER, and that is the worst formulation of carbidopa levodopa ever made, and it doesn't work near as well as the IR, and clearly don't even compare that with Rytary as a long-acting formulation of levodopa. Now, here you have the three quote-unquote standard formulation of levodopa. The IR, the old quote-unquote Cinemet, the CR that I told you, forget about it, and then you have the real extended release carbidopa, levodopa, brand name Rytary. Okay. This is Common Sense 101. And I'm going to skip and talk with, I'm going to wait for your question that should be coming pretty soon. Okay. This is very important. This is a progressive illness, and your medications need to be adjusted every so often. But I'm going to tell you, the better your treatment is from day one, the more steady your course will be over time. And I'm here to tell you that if you treat a person well from day one, they will be really boring patients. I had a patient here last week, has been with us for 12 years. And this guy, his most significant problem has been under my care with the Parkinson's, that a year ago, he decided to climb a tree to trim bushes and so on. He fell from the tree and broke his neck, and thank God received emergency surgery, and he's walking and so on. But the guy is very active, and his medications are adjusted, I don't know, every couple of years or so. So anyways, learn about the progression of your symptoms, report to your doctors, and you need to be your first advocate. You are the ones who know how difficult or how easy it is for you to take care of you, in terms of your activities of daily living. And patients with Parkinson's need to understand that the treatment is to keep you free. The treatment for Parkinson's is not just to prescribe drugs and refill drugs, and you get worse and you get worse. And then you hear from some doctors, or hopefully you won't, but I have heard this before. Well, what else do you want? You have Parkinson's. This is an incurable disease. I want to hear who is the doctor that is treating all curable diseases, because we cure nothing. We only cure a few cancers and a few infections. We don't cure nothing. So we know how to treat illnesses, palliating symptoms and optimizing quality of life. And Parkinson's disease is the most treatable neurological disease by far. Is the most treatable. Okay. All right. Here is what you don't like. That you need to eat well, that you need to go to bed and rest, but you need to be good in terms of sleep hygiene. You don't need to be in bed 10 hours a day. 8 hours is the max you're going to be in bed, awake or sleeping. And you need to use the 4-letter word, exercise. Okay? Exercise is for many of you a 4-letter word. And I'm telling you, it is the best remedy for Parkinson's, and it's going to keep you young and out of trouble. I call it, they call dopamine. I call it edupamine. Edupamine is education and Parkinson's, and education and Parkinson's go along. And the more edupamine you take, the more in control you'll be, and the more you'll be able to tell your doctor, what's going on? Why am I having this dyskinesia? When are we going to modify the treatment, or why don't I use this or that treatment to reduce my off time? Uh, God is very busy these days, and God is not really that able to make miracles for us. And I'm going to be nice with my doctors. I guess that many doctors are very busy today to practice medicine. You guys have to open your mouth with knowledge and say, one moment, how come I am taking 7 times a day cinnamon? I heard that there is a better way to treat Parkinson's than that. Guys, I see patients in my office coming for the first time, taking 10 and even 12 doses of levodopa, which is insane. So yeah, take dopamine, but take also educamine, okay? And empower yourself with that. So what did we learn today? Well, that off time and Parkinson's are different for each one of you, that you don't need to live in misery, that there are better treatments for you available, okay? And as time goes on, you're going to need adjustment in your medications. You may even need surgery. Not everybody needs surgery, but surgery is great for Parkinson's when it is the right patient for the right reason and in the right hands. Not only the neurosurgical hands, but also the doctor managing your medications before and after the surgery. Okay? And the idea of Parkinson's in terms of responses to the medications is to keep you in a good on as long as possible. Okay? Now, questions and answers will come.
Awesome. So I do have a question. Someone had asked what you feel the maximum dose of levodopa is.
Well, that's a good question. That's a good question. And there is no maximal dose in the sense that everybody is different. And I have patients that are using, let's say, Duopa, and using Duopa, they are receiving 1,000, 1,200 milligrams of Duopa. There are patients that are on Rytary and the numbers in Rytary are different. And that could get you confused in the sense that when you look at a patient on Rytary and that person is taking, let's say, 2 capsules of 245 milligrams 4 times a day, when that person is taking 8 capsules a day of Rytary, if you equal the levodopa into the milligrams of the older formulation, the IR, those 8 capsules of Rytary equals to only 600 milligrams of the levodopa in the IR form. And that patient is getting more robust symptomatic treatment. He or she is on longer than the IR that is taking 1,000 or 1,200 milligrams. So the question shouldn't be what is the maximal amount, is how much you need as a patient to have the optimal response. And that I cannot answer because, that's individualized and that requires an evaluation. It's face-to-face treatment and assessments.
So this person wants to know, do you think it matters if you take levodopa with food, particularly, I think they wrote portions, but I'm wondering if they mean protein.
Yeah. The protein is the problem with Parkinson's, with levodopa. And the problem is that when protein and levodopa both are in the stomach says, hey, levodopa, sorry, but I'm going to give priority to the protein. So you won't absorb the full amount, that particular dose. But I think that many of you go crazy about this and go through unnecessary complications. Listen, very few of us will have a Western omelette with sausage and ham and cheese and 3 eggs every morning, okay, for breakfast. And if you are that lucky that you do that every day, then all you need to do is to take your levodopa 1 hour before or 1 hour after that high protein content meal. If you want to have a 14-ounce ribeye medium tonight, you could have it, but have your levodopa 1 or 1.5 hours away from that dose. And because you cannot move the levodopa timing that far, move your meal. That's the simple answer. And granted, there are patients who have gastroparesis, bad constipation, that if they, for example, have a high content meal and then they have the levodopa like an hour later, those patients may have problems because the transit in the GI tract is so slow because of the gastroparesis and the constipation that the absorption may be delayed even if you take the medication 1 hour after the meal. You follow me? I hope that was clear.
We have time, I think, for one more question, and this is sort of related to lifestyle, related to symptoms. So this person wants to know, how does one work through debilitating fatigue to exercise? I used to train like a professional dancer and a cyclist, so I understand how important that is.
Well, motivation is not sold at Walgreens. Motivation we find with support from the family, with treatment of depression. Many times we are fatigued and it is kind of connected or worsened by depression, lack of motivation to make it to the gym. My motivation to go to the gym Monday, Wednesday, and Saturday? I have 2 reasons or 2 big motivators. Number 1, I don't like doctors. And number 2, they have my credit card. So those are motivations for me. And guys, fatigue is a pain, but it has been shown that patients that engage in long-term program of exercises, the fatigue improve. Do yoga, do Tai Chi, do exercises that are perhaps easier for patients with fatigue, but also helpful for your own mood and feelings and state of mind. You know, it's a fact. When you do these exercises, your mind works better. When I go to the gym first thing in the morning before I come to the office, the girls here know that. I am less cranky. I am less irritable. I have more endorphins in my system. I'm happier. Just like when I'm talking to you guys.
Well, and we're happy that you're talking to us. I'm going to do one more question and then I think we will be at our close. And I guess this is obviously going to be specific to needs, but do you have a general like recommendation of how often people should be seeing their movement disorder specialist?
Yeah, well, again, that's very variable because everybody has different problems. Uh, some patients, let's say, some patients who are moderate to advanced disease, they need to be seen every 3 weeks. Some other, excuse me, every 3 months. Others I see like today and then I see in 6 weeks to see how things go. It's very variable. Now, early on, you could see patients every 4 or every 6 months, and that's fine. But the more advanced, the more complicated the case is, the more closer they have to be seen until the disease is stabilized, okay, or optimized. And guys, it's not how often, it's how productive the meeting with your doctor is. You know, big deal that you see your doctor every 4 months, but you live there with no improvement.
Well, I want to thank you so much, Dr. Gill. This was a great overview of everything you need to know. And I appreciate you taking the time and sharing your expertise and your stories and
You're very
your
welcome.
humor. It's always fun.
You're very welcome. You guys take care. And for those of you who are in the southwest part of Florida, our upcoming symposium for April, Parkinson's Awareness Month, is on Friday, the 5th of April. Okay? 10 days before our famous tax day. So God bless you and have fun. All right?
Well, and I'm going to invite everybody to give you their gratitude wave from across the miles in the United States. So thank you so
Bye,
much, Dr.
Christine.
Gill, and thanks to Amneal for giving
Thank,
us this
thank you,
opportunity.
Amir. Yeah, thank you guys. Bye bye.
Bye.